Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is April 18, 2025. This video is on a JAMA review titled Management of Staphylococcus Aureus Bacteremia, a review published online April 7th, 2025. The killer bug, why Staph aureus still terrifies. It remains a global menace with a mortality rate 15 to 30% and around 300,000 deaths annually. It's no ordinary bloodstream infection. Over one-third develop metastatic foci, endocarditis, vertebral osteomyelitis, epidural abscess, etc. Risk factors, think devices, cardiac pacemakers, catheters, diabetes, injection drug use, and previous Staph aureus exposure. Diagnostics starts with blood cultures, but early imaging and rapid diagnostics, example MEK gene for MRSA, improves outcome. T is your friend if you suspect endocarditis. VIRSTA score can help decide when. Bugs versus drugs. Treatment was start empirically with vancomycin or daptomycin, cover MRSA until susceptibilities are known. MSSA, de-escalate to cefazolin or anti-staphylococcal penicillins, faster killing, fewer side effects. MRSA options include vancomycin, daptomycin, or the new kid in the block, ceftobiprole, FDA approved in 2024. Combo therapy, example daptomycin and ceftaroline, hasn't shown mortality benefits in trials. Persistent bacteremia, what do? Time to reassess for source control and consider switching or adding agents. Seek and destroy, source control is king. Staphylococcus aureus bacteremia isn't just a blood problem, it seeds deep. Joints, spine, valves, and devices. Always evaluate for metastatic infection, MRI for back pain, PET-CT for elusive foci, and TE for valves. Source control is equivalent to survival. Drain abscesses, remove catheters, explant infected devices. Delay kills. Each extra day without source control raises mortality risk by 16%, double digit. Infectious disease consults aren't optional. They cut long-term mortality by 29%. They are mandatory. From IV to PO, is the oral route ready? Traditional doctrine, 2 to 6 weeks of IV antibiotics, especially for complicated cases. But POET and Sabato trials show some low-risk patients do fine switching to oral therapy after initial IV. What are the criteria? Stable vitals, cleared bacteremia, no endocarditis or hardware, and rapid response to therapy. Caveats, no MRSA in these trials, and strict selection criteria, limit generalizability. Future trials may redefine how we treat Staph aureus bacteremia, but for now, start strong, image early, de-escalate smart, and control the source. Podcast brought to you by Master MedFacts at mastermedfacts.com.